Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome to this episode of the Radiology Review podcast. This is part 2 of my discussion on HIDA scans. If you have not heard the first part of the discussion on HIDA scans, feel free to tune into the previous episode. This will again be presented in a question-answer format, and let's go ahead and get started. First question, how long must you wait on a HIDA scan to see gallbladder activity before you call acute cholecystitis? Think about that for a minute. How long do we wait for the gallbladder to show up on a HIDA scan before we call acute cholecystitis? And the answer to this question is 4 hours. Note that I did not mention anything about doing any special modifications or procedures to the protocol to help speed it up. But on its own, after you inject radiotracer, you should typically wait 4 hours before you say there is no gallbladder activity. Therefore, the cystic duct is obstructed and acute cholecystitis is present. Now, what if you don't want to wait 4 hours? Is there anything else you can do to speed up the process? And the answer is yes, but what can we do to speed up the process so that we can call acute cholecystitis earlier than 4 hours? And the answer is that we give morphine, and morphine promotes gallbladder visualization. And what is the mechanism whereby morphine augments gallbladder visualization on a HIDA scan? That is the next question. What does morphine do to allow us to see the gallbladder more rapidly if the gallbladder is not inflamed with acute cholecystitis? And the answer is that morphine constricts the sphincter of Oddi, that's ODDI, sphincter of Oddi, which then increases back pressure in the biliary tree to promote gallbladder filling. So in other words, you give morphine, the sphincter of Oddi constricts, the bile now has more difficulty entering the bowel, which increases the back pressure in the biliary tree, and that back pressure promotes gallbladder filling to allow us to see the gallbladder on the HIDA scan. Related to that topic, what opioid does not typically constrict the sphincter of Oddi? This is kind of a question that I think is worth knowing because I've seen it pop up from time to time in board preparation materials. And the answer for the opioid that does not constrict the sphincter of Oddi, at least as much as other opioids do, is Demerol, which the generic name is meperidine. Demerol, also known as meperidine, has less sphincter of Oddi constriction, so we obviously would not want to use Demerol to promote gallbladder visualization. But on the other hand, if a patient is in severe pain and needs opioids, your opioid of choice for a patient that is planned for a HIDA scan would be Demerol. After how many minutes is morphine typically administered for a VQ scan? So think about your protocols. We often don't give morphine immediately, but we give the gallbladder a chance to show up on its own. And if it hasn't shown up within what amount of time, do you then say it's time to bring the morphine out? And the answer to this question is that you can administer morphine after 30 to 60 minutes if the gallbladder is not visualized. And that's 30 to 60 minutes after injection and start of imaging. You then need to image at least 30 more minutes after morphine has been administered before you would call gallbladder non-visualization and acute cholecystitis. Note that an expedited protocol has been proposed whereby you give morphine initially at the time of initial radiotracer injection, but I don't think the boards are likely to ask about this, and I think most centers still are not doing that protocol. So what I would remember is that you wait 1 hour for the gallbladder to show up on its own. If it does not show up, then you can give morphine to speed up the process and wait another 30 minutes. If you still do not see the gallbladder 30 minutes after morphine, you can call acute cholecystitis. If for some reason you do not want to administer morphine, you then need to wait a full 4 hours before you would say the gallbladder is not visualized and therefore acute cholecystitis is present. Remember that I discussed on the previous episode that if you do not see the gallbladder within 1 hour, that can be either acute or chronic cholecystitis. If the gallbladder shows up between hours 1 and 4, that would be chronic cholecystitis. If the gallbladder does not show up at all during that time and you image it 4 hours and there's no gallbladder activity, that is acute cholecystitis. Next question. Is there anything else you may consider administering along with morphine if you are performing morphine-augmented imaging? There is something else you can administer to help your imaging be better. The answer I am looking for is that a booster of radiotracer, which is often 50% of the original radiotracer dose, can optionally be given at the time of morphine administration to make sure that you have enough tracer in the liver for biliary secretion and eventual gallbladder visualization. If you give morphine when the tracer has already washed through the liver and biliary system, there simply may not be enough tracer left in the hepatobiliary system to see the gallbladder. So when you give morphine, especially if you check the image and liver uptake is weak and it has largely washed out, give a 50% booster of the initial dose, and that will help you avoid potential false negative. Scan for acute cholecystitis, which can occur when you give morphine but there is no longer sufficient tracer in the liver to subsequently fill the gallbladder. Can you perform a scan for acute cholecystitis on a patient who is already on morphine? If so, how will the presence of morphine affect your imaging? The answer is that you can still scan. This does not limit the ability to see gallbladder filling to evaluate for acute cholecystitis. Due to increased sphincter of Oddi constriction, however, this may delay transit of tracer into the bowel. Therefore, some say you should wait 4 hours for the morphine to wear off, but this is not required but is optional. What are some patient contraindications to give morphine for a scan? All right, you can't just go give morphine to everybody without considering whether they are a good candidate, and I do think you should also know this for board exams. If a patient has increased intracranial pressure, especially if they are a child, if a patient has severe respiratory depression and are non-ventilated, if a patient has allergy to morphine, these are absolute contraindications. So one more time, absolute contraindications to morphine is a patient with known increased intracranial pressure, particularly if pediatric, a patient who has severe respiratory depression and is not on a ventilator, or a patient who has a known morphine allergy. A relative contraindication to morphine administration is acute pancreatitis, because increasing the sphincter of Oddi pressure can potentially make pancreatitis worse. What does it mean on a HIDA scan if you have prompt hepatic uptake but delayed excretion into the biliary system? What can cause this? So one more time, prompt hepatic uptake but delayed excretion into the biliary system. First of all, if you see prompt hepatic uptake, this means there is no hepatic dysfunction, so this is less likely to be due to acute common bile duct obstruction, as that does cause some hepatic dysfunction, which would manifest with delayed hepatic uptake and delayed biliary secretion. In this setting where you have prompt hepatic uptake but delayed biliary excretion, potential causes include medications such as Dilantin and oral contraceptives. So tuck that away. Again, the key is that Dilantin and oral contraceptives can delay biliary excretion but do not affect hepatic uptake. So you would see prompt hepatic uptake, delayed biliary excretion. You can raise the possibility that the patient may be on Dilantin or oral contraceptives. What agent do you administer to cause gallbladder contraction, and why might you want to do this during a scan? The answer is that to cause gallbladder contraction, you can give Syncolide, also known as CCK, and you would use this in the setting of chronic cholecystitis evaluation as a reminder. And after you see the gallbladder, so you've already excluded acute cholecystitis, you give CCK and cause gallbladder constriction, and you can then use your pre and post CCK imaging to calculate the gallbladder ejection fraction. Now, if Syncholide is unavailable, what other options do you have in order to get the gallbladder to contract so you can calculate an ejection fraction? The answer is that you can give the patient a fatty meal to stimulate gallbladder contraction, then image. I have seen protocols use a protein and fat heavy shake like Boost. I've also seen at least a few cases where the patient was instructed to go walk around the cafeteria, and just being around the smell and environment of food can cause the gallbladder to constrict, and you can then go back and calculate your ejection fraction. But for the board exams, I would know that a fatty meal can be used as a replacement for CCK to cause the gallbladder to contract for ejection fraction calculation. Now, a fatty meal may potentially be less standardized than CCK administration, but I wouldn't get too caught up in that for board exam purposes. Next question, what is a potential indication for hepatobiliary scintigraphy in a newborn? All right, I hope you're all familiar with this. HIDA scans aren't only for adults, so why might we perform hepatobiliary scintigraphy in a newborn? And what I want you to answer is that you can perform hepatobiliary scintigraphy to evaluate for biliary atresia versus neonatal hepatitis. That's very important, and you definitely need to know the difference between these and how imaging would manifest for biliary atresia versus neonatal hepatitis. How do you tell between biliary atresia and neonatal hepatitis on a HIDA scan? Go ahead and hit the pause button and think about this if you need. The answer is that if you see transit of radiotracer through the liver and biliary system into the bowel, this is neonatal hepatitis, because you must have a biliary system in order to see transit of radiotracer into the bowel. Biliary atresia will not show bowel activity no matter how long you wait or how much radiotracer you administer, because the biliary ducts are atretic. Biliary atresia, no bowel activity. Neonatal hepatitis, you will eventually see bowel activity if you wait long enough. So how long do you wait to see bowel activity before you consider the possibility that this neonate actually has biliary atresia instead of neonatal hepatitis? The answer is that you need to wait at least 24 hours. Okay, 24 hours is the minimum amount of time you wait. If you don't see bowel activity at 24 hours, what is the next step? The answer that I'm looking for and that you should know is that you should then give phenobarbital, and that phenobarbital supercharges the hepatocytes. I've heard some sources say it helps the hepatocytes mature more rapidly, and you increase the chance that the liver will be able to successfully uptake and excrete the radiotracer into the biliary system and subsequently bowel, and you then repeat the study. So in a neonate, when you are looking for neonatal hepatitis versus biliary atresia, you inject the radiotracer, you image for up to 24 hours. If you still do not see bowel activity, you should give phenobarbital to supercharge those hepatocytes, and you repeat the study and wait another 24 hours. If you still do not see bowel activity after giving the phenobarbital, after waiting an additional 24 hours, this then supports a diagnosis of biliary atresia. You need to know what the name of the surgical procedure is that is used to correct neonatal biliary atresia, so that's my next question. What is the name of the surgery for biliary atresia correction? The answer is a Kasai procedure, Kasai, Kasai procedure, and you should know that you will have a better outcome for that neonate when the Kasai procedure is performed earlier versus later. So the prompt diagnosis of biliary atresia is important. Next question. What is an indication to perform a HIDA scan in a patient who has had a cholecystectomy? Why in an adult might you perform hepatobiliary scintigraphy if their gallbladder has been removed? The answer I am looking for is for evaluation of a bile leak. You inject the radiotracer, You watch the tracer uptake and transit through the liver into the biliary tree. If you see something in a patient that is post-cholecystectomy that looks like a gallbladder, do not assume that the surgeon did not remove the gallbladder, but assume that there is a bile leak that is causing that radiotracer to accumulate in the surgical bed. Additionally, you should scrutinize the right paracolic gutter and pelvis for increasing activity that appears to be external to the bowel, and that will also confirm that a bile leak is present. Next question, what is the reappearing liver sign and what does this sign mean? Hit the pause button and think about this if you need to. What is the reappearing liver sign? What does this sign mean? The answer is that the reappearing liver sign happens when leaked radiotracer from a bile leak tracks superiorly around the perihepatic space and coats along the surface of the liver, which gives the appearance that the liver is reappearing instead of washing out like you normally expect. If you see an initial decrease in liver activity followed by a paradoxical increase in activity, and you have not administered additional radiotracer, then you can assume that this increased liver uptake is due to tracer around the liver instead of tracer within the liver, and that tracer around the liver got there through a bile leak. So the reappearing liver sign on a HIDA scan confirms a bile leak. I would expect if they are asking you about this topic on a board exam that you will have some sort of surgical history that will cue you in that a bile leak is possible. So the final question is this. Focal liver uptake on a HIDA scan is most indicative of which liver lesion? Think about that for a moment. And with recognition that this is certainly not a specific finding for this entity, and that multiple liver lesions could in theory take up some degree of HIDA radiotracer. If you do see focal liver uptake on a HIDA scan, this is most indicative of which liver lesion? The answer I would remember for board purposes is focal nodular hyperplasia. You can also see uptake of sulfur colloid with FNH. But if they show you a HIDA scan and there is a focal liver lesion, this should probably make you think first of focal nodular hyperplasia. And typically that liver lesion will become more manifest on washout images, so the tracer will wash out from the rest of the liver and it will remain relatively higher in the liver lesion with slower washout in the focal nodular hyperplasia. I will get a more detailed discussion of liver lesions on a later episode. I hope these past 2 episodes on HIDA scans have been helpful for you. Thank you for taking the time to listen to this podcast. Keep up the good work. Keep studying hard. Remember that you have to study really hard to succeed on radiology board exams, but you can do it. I have made a downloadable study guide available on my website, theradiologyreview.com, that reviews these questions and answers I've asked for HIDA scans. So go ahead and go to my website, download this, and check it out. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.